all these talks, we can really spend a lot of time in questions after them. In order to proceed with the material we have for today, I'm going to talk next about the Colvin Prize and the winner of the Colvin Prize, whose name is Dr. Nolan Williams. Dr. Williams comes to us as an associate professor of psychiatry and behavioral sciences at Stanford. He's a director of the Stanford Brain Stimulation Lab, and he's a member of the Neurosciences Institute at Stanford, the Wu-Tsai Neuroscience Institute. Dr. Williams was educated really at the Medical College of South Carolina. He did his medical school there, and then he did a psychiatry residency there, and he also did a neurology residency. And he is now triple board certified in psychiatry, neurology, and in a kind of a new field in psychiatry, which in psychiatry, the field is called neuropsychiatry. In neurology, the field is called behavioral neurology. I think I got that all right. And all of the medical schools around the country now have groups of doctors who are in this behavioral neurology, neuropsychiatry business. Dr. Williams, he didn't get the Colvin Prize because he's a neuropsychiatrist. He got the Colvin Prize based on his activities in neuromodulation, really. One of the most recent things, and one of the things that he's most known for, is a neuromodulation routine called the Stanford Accelerated Intelligent Neuromodulation Therapy. And you might think that's really hard, but it's called SAINT. So if you take the first letter from each of the words, and SAINT, of course, is a wonderfully positive word, and it's easy to remember. So he developed the SAINT technique in neuromodulation. It's a rapid-acting neuromodulation technique in depression. It certainly produces an outcome faster than any other neuromodulation treatment. I'm wondering also, and I think he may talk to us today about this, is if it produces a better outcome. Say if you're making a snowball and if there's a snowballing effect and you actually get to a better depression. So that a focus of his work is treatment-resistant depression, and another aspect of his work is psychedelic treatments. Ketamine, another treatment he's working on, which is Ibogaine. He has also in the past been interested in deep brain stimulation. Deep brain stimulation is an emerging technique in, if we just get everything right, the emerging theme in treatment-resistant depression, and he'll tell us more about that. With that, I'll introduce Dr. Nolan Williams.
Carol. Thanks for having me here. Really honored to be here, and I wouldn't be standing here without my students and postdocs who have worked tirelessly over the last decade on what I'm about to show today. And it's really inspired by the experiences Carol talked about. As a psychiatry and neurology resident, what you do is you go back and forth between the neurology ward and the psychiatry ward, as an intern, the cardiology unit. And when I was on the cardiology unit, I recognized there's this clear process in medicine, right? Where any doctors in the house? A few. So if I start having chest pain right now, you're going to run up and you're going to check my pulse, and maybe you have an aspirin that you're going to give me, and what are you going to do next is call 911, where you're going to get me to the emergency room where there are more tests and more treatments, right? That's why we call 911 for the rest of medicine. And then if I'm truly having a heart attack in the ER, they determine that's going on, then they escalate my care further into the cath lab where there are more tests and more treatments, right? In psychiatry, it's different, as you all know. If a private practice doctor is seeing a patient in the community and the patient voices suicidal thinking, right? the psychiatrist or psychologist will step out of the room, we'll call the 911, they'll come and evaluate the patient, but they have to be put in the back of a squad car and they have to be put on a legal hold, where they too go to the emergency room but end up, in many cases, boarding in a hallway bed, waiting on a psychiatric bed for sometimes a week at a time. And this is kind of the part of the sad reality of what happens in the processes for psychiatric care even in 2024. Patients that get up to the psych unit then realize that unlike the rest of medicine that they're used to, where you escalate the acuity and you increase the number of tests and treatments, in almost all circumstances, the patient ends up with the same oral antidepressant availability that they had as an outpatient. And then they realize that they're at this kind of peak, worst point in their life on this inpatient unit, and there hasn't been in the past a treatment designed for this problem, right? We all take care of patients in the room, and listening to this on the web, know this sad reality. And with that, the highest risk of suicide in an entire lifetime of a mood disorder patient is in the 3 months after they get discharged out of the psychiatric unit, right? So I've committed a lot of my life to depression, trying to find new treatments, and trying to really solve this problem, right? This problem that we've got the leading cause of disability worldwide in depression, and we have treatments, but those treatments as a generality don't match the acuity of the illness. And some of you may be thinking, well, electroconvulsive therapy is still used, and that's an option, and we use that on inpatient patients in the United States, but the reality of that is only 10% of US psychiatric hospitals have it. Only 1 out of 8 patients elect to do it. And what that means is only 1.5% of patients that meet Medicare, Medicaid criteria to receive it in the United States. So it's not a scaled treatment. It hasn't scaled over the last 30 years. It is very unlikely in its current form to be a standard of care for this problem. And where I see patients is really in this green box. That's when they get to me. When we know they've got depression, they've had a medical workup, they've gone through a primary care doctor and usually a general psychiatrist, and then they come to see us when nothing has worked. And the clinicians in the room know this data, but for others that are more new to mood disorders, moderate depression has the same disability as having that acute heart attack. And severe depression has the same disability as dying of cancer without a treatment. And I've had a number of patients that have told me in their worst state of depression that they'd rather be in that dying cancer without a treatment because at least people would understand. And so we are trying to solve this problem of an average length of stay of 7.4 days in the United States and this peak suicidality at discharge of 3 times the rest of the lifetime. And the idea is, can we take this nearly or more than 500,000 patients and develop and engineer a treatment that's capable of producing rapid acting change? And so we've known that TMS is an approach that has been around for some time, and it functions like if you can think about it like a scalpel and not a pill, that you can do a whole lot of things with this device. You can stimulate in a whole lot of different ways. And that first kind of TMS was really a technology that was derived from early kind of safety approaches that were less efficient, but just like the telegraph and then the telephone and now our smartphones, we're capable of producing much more physiologically relevant effects. And so this was the original TMS approach in its conception. And this approach was quite slow, right? It was developed to effectively be treatments over the course of 6 weeks. It took an hour for each treatment, and it wasn't personalized, as I'll show you in a second. And so with the original TMS approach, in an interest in the mid-90s to make this scalable, the goal was to try to find kind of an easy metric using essentially trigonometry on a curved 2D surface to develop a general positioning of the TMS coil within the dorsolateral prefrontal cortex, and with that, an average spot that everybody could stimulate on the skull. But the skull spot and the brain spot are not the same in any two people, and therefore, in some circumstances, you're going to try to hit a brain network node, and you end up, unfortunately, missing that node with skull-based targeting. So, we really thought about how do you stimulate in a way that can really increase the speed. If you can get into the right target, which I'll talk about in a second, how can you increase the speed of stimulation? And you can do it by using hippocampal rhythms derived from basic science experiments from the last 30 years. And you can actually play those hippocampal rhythms, those memory signals, back into the brain using this TMS technology. And when you do that, you can make the stimulation quite a bit more efficient than you would have otherwise. And so you can stimulate with these hippocampal rhythms, and we do it for about 9 minutes of stimulation because that produces the greatest excitability change. And then we use this idea of space learning theory where we actually stimulate and then we wait a certain period of time, an hour, which is kind of an ideal period of time in between based off of memory studies, to then stimulate again. We're really recapitulating the way that the memory system works exogenously using a stimulation approach. And we're really sending a signal like a telegraph where the sender is the stimulation device and the receiver is the human brain. And so we were able to find a way to reorganize the stimulation in time so that you can take a 6-week course of the original kind of TMS approaches and compress it down into a single day. And that's really the idea here, is how do you rapidly stimulate the brain and produce an antidepressant effect that can solve that clinical problem I talked about earlier. The problem of trying to address an emergency in 7 days and reduce the risk when people leave the hospital. And so we were able to give, about 7.5 months worth of stimulation with the, based off of the conventional way of thinking about this in 5 days. And with that, really, as I'll show you in a second, speed up the approach. But it's not just about the how and the how much, it's also about the where. Others have spoken about this before me, the importance of brain networks as it relates to thinking about stimulation. And so in this kind of oversimplified model, the way that we have thought about stimulation is around this balance between the dorsolateral prefrontal cortex, the control center in the brain, and subcortical regions, and regions like the subgenual anterior cingulate, which are overactive in depression. And when you do individual brain maps with patients using fMRI, resting state functional connectivity, you can actually derive spatial positioning of these networks and find this kind of ideal stimulation target between the left dorsolateral and the subgenual cingulate. And when you do that, you can actually utilize modern techniques derived from functional neurosurgery, where you can actually register the brain in 3D space, find the functional connectivity target that is embedded in a unique structural target, and apply the stimulation over the cortical region of interest in a consistent way across patients. And so that is what we call the same technology, this where within the left dorsolateral prefrontal cortex, the how, this kind of memory-based stimulation approach and the how much, really doing this sort of dose-response studies that were conceived of with the original TMS approaches, but weren't really possible with the early technology. But we now have the technology to do it, where we can actually do really robust simulation approaches. And so in our second published trial in the American Journal, we treated folks, many of whom had failed 5 or more meds. And what we found was that in patients with severe depression, we can have them cross the remission line in an average of 2.6 days. And so we were able to produce, rather rapid improvements in their symptomatology in a short period of time. In our follow-up randomized controlled trial, we had patients in an average of 9 years in the current episode, 20 plus years current lifetime load, 50% on disability, an average MADRS score, which is in the severe range, and we were able to produce an antidepressant effect that was quite robust and separated from sham in every way that you analyze the data, and those are response rates on the bottom. And so, quite striking for us. We were happy with this result. We then took this same data and used something that one of my postdocs, Anish Mitra, developed also at WashU. It's like the theme of the week, that there's a lot of WashU folks here, to look at the relative lag between 2 network nodes as it relates to bold fluctuations. And he found that normal healthy controls, the dorsolateral, temporally preceded the cingulate, and worked with Marcus Rakel on a lot of these methods when he was still at WashU. And in depressed individuals, if you do this with scans before and after, you can actually see that in people that received SAINT, they were able to flip that temporal pattern such that the left dorsolateral preceded the cingulate like the healthy controls. We replicated it in a second data set, and that change was correlated with changes in the depression score, the MADRS score. But if you look at the pre-treatment lag in the depressed individuals, it was flipped, so that the cingulate actually temporally preceded the dorsolateral and the anterior insula. And if you contrast that to our healthy controls, and actually a WashU healthy control data set, we saw the same thing, right? Which is in normal healthy controls, it was left dorsolateral temporally in front. And in highly responsive SAINT patients, the number of them that had this flip of the cingulate with the dorsolateral was much greater than the non-responsive individuals who looked like the normal healthy controls. And so that contrast that you saw here with the depressed patients and the normal healthy controls was seen also between the responders and the non-responders. And we published this in PNAS last year. And so it's this dream, right, that we hopefully will have at some point, and this is early data, we need to replicate this, there's lots of work to do, where just like when you walk into the primary care doctor's office, you have 10 patients who have headache, polyuria, polydipsia, you get a blood sugar on all of them. Some of them have diabetes, some of them don't. Some of them have something else. And if you give insulin, the blood sugar normalizes, and you can see that in the post-test. And so this idea of being able to use perturbation as a mapping technique to really understand the underlying neurobiology of these problems, we think is a very powerful one. And so not just therapeutic development, but also perturbation of networks and really trying to understand what underlies these conditions. And so we've been fortunate enough with this technology to receive FDA clearance, breakthrough status before that, and the first innovation funds for Medicare to pay for it. And so starting in July, Medicare was paying for all this technology for inpatients and outpatients. And the dream is that a patient can walk into the emergency room, they can receive a scan, they can be treated, and we hope leaving better with less risk than when they walked in. So thank you for all of this support. Thank you so much. I have to say, BBRF was the first grant that we had for this approach, and we wouldn't be here without the support of this great organization. So thank you so much.
So I'm going to take the prerogative to ask the first question.
Great.
Can you take people and make them better after the SAINT than after the long treatment? I know you can't do it. I know it does it faster, but do they get better?
Yeah, no, it's a great question. So, I don't know if there are any Precorial reviewers in the audience or online, but we're in process of trying to answer that question now. And it takes one of these big grants to do it. These kind of comparative effectiveness grants, and so the effect sizes for this are quite large. So if you're doing an effect size comparison, you can see a larger effect size, but the trial is yet to be done, and it's a trial that I really want to do. But we, in that first study, and I didn't show this data, we have had a number of people who have failed conventional TMS. Oh, I took slides down. Failed conventional TMS, and we treated them with this, and we were able to have them remit. I haven't had anybody go the other direction, where they've gotten SAINT, they didn't respond, and then they responded with conventional TMS. So.
I, of course, read all the newspaper reports, and I thought that they got better than the prolonged treatment in the newspaper.
The newspaper made, as a scientist, without doing a randomized trial, I don't want to overstate the evidence, but in our hands, we've seen a whole lot of folks, like I said, that have failed conventional TMS that have responded to this.
Sure.
Again, keeping with the WashU theme, I graduated med school from WashU in '83. So it's tremendously exciting. I've been following it since you first presented some of your stuff here at BBRF a few years ago. And, the one issue that I worry tremendously about, a lot of these things are very user-dependent. Mm-hmm. And the fidelity of doing it correctly, because I've been using quote-unquote SAINT protocols, not with you, but with other institutions, Columbia, Harvard, and all the rest. And it's exciting. That's part of the question, is how do we guarantee the fidelity to your methods? And two, has there been any comparison? I know ECT is hard to scale.
Yeah.
But it's, I'm fond of saying we have these amazing modalities, ECT, lithium, clozapine, CBT, and now I'm hoping SAINT, tremendous, and deep brain stimulation, great modalities. But how does it compare? So two-part question.
Yeah, no, and sorry.
I don't think that psychiatrists are so dumb that they can't maintain fidelity.
Yeah, so I'll answer your second question first and then your first question. So, I think there needs to be kind of a STAR-D for treatment-resistant depression. A lot of us have talked about this idea of can we go even later on the algorithm, right, where we're really looking at these folks that have kind of gone through most or all of STAR-D, and then now, they're still ill, and what can we do there in comparing? And there's been some work with, obviously this ketamine versus ECT trial, but it's going to take quite a bit of funding to do that. And so, TBD, we've done some work in ECT failing folks that have responded to this. We'll show some more of that kind of data. As far as the fidelity piece, I think both are important, right? So you need other groups to try versions of this. I think that's going to be helpful to figuring out what the therapeutic kind of index is from a spatial kind of certainty standpoint effectively. And then, you've also got to develop technologies, likely through other, non-academic means to be able to produce software that makes it really straightforward to do this. And I think both of those things are happening, right? So you've got other groups, and Penn had a great paper with bipolar depression recently. They had a positive RCT, using, basically, a recapitulation of what we've done. And so, you've got kind of both of those going on right now, and I think we're going to get real answers from both of those kind of approaches. And the hope is you can have a technician, a medical assistant or something like that with, an hour of training, and the software is so user-friendly that you can just do it. Yeah. Oh, it is. It is, yeah.
We'll pass on all the questions, and I'll put them off till the coffee break.
Have you did you work with veterans in any of this? And did you have a different response?
You better repeat the question.
Yeah, so the question was around veterans. And so I've worked, with veterans. We haven't, for these neurostimulation trials, we haven't recruited specifically veterans. We have treated some veterans. They've done quite well. We did publish a paper, and Carol alluded to this earlier, with ibogaine, specifically in Special Forces veterans who were going to get treated for TBI, PTSD, and they did quite well, and I'm happy to share that paper. And so that's been more of the veteran work, is more in the psychedelic space, and it's by happenstance more than specific decision making. But we're very committed to veterans and see that as one of the core groups that we want to help, for sure.
Thank you, Doctor.
Thank you. Thank you so much. Yeah, thank you. Thank you.